CataractCoach.com. We have a complete case shown from start to finish, a dense posterior sub-capsular cataract with a shallow AC. Let me show you this interesting case here. So you can see centrally there's a very dense posterior sub-capsular opacity, absolutely confluent from one edge to the other. And there's no light coming through there. This patient has a pre-op vision of count fingers only. And this patient's also very hyperopic. We're going to put in a high power lens here, 27 diopter IOL. So you know this patient's going to have a shallow anterior chamber, short axial length. We'll put the viscoelastic in. And you can see we can't do our normal technique coming across the eye. We just have to go to the side there because the AC is so shallow and that anterior lens capsule is so domed forward. Now we'll make our incision very important. We want a nice incision in this case. So let's be very deliberate and careful here. Make sure the tunnel length is good. That looks great. Great incision. Now to do our capsulorhexis, we're going to measure it. We're going to use our forceps that have these marks. And you'll be surprised that a 5 millimeter rhexis in this eye is going to look quite large. And that's because it's a small eye. The anterior segment small, the white to white measurement small. We're creating this capsulorhexis here. And we want to make sure we have a nice intact round capsulorhexis, about 5 millimeters, maybe 5.5 millimeters in diameter. There is a chance we're going to have to put in a sulcus lens on this patient, or optic capture lens. We have to have, preparations for all that. So here's our capsulorhexis. Looks pretty good. Measuring it out, just a little more than 5 millimeters. Now with hydro dissection, you got to be very careful here. I don't want to be forceful, so I'll do a little. And it doesn't really look like it goes across that opacity. I try again the other direction. I'm not really sure. So try one more time. Now this is not a posterior polar, but I just worry that maybe there is a weakness in that capsule. And I'll try to rotate the lens, and it really doesn't want to rotate. You know what? Let's leave it alone. Let's do it without rotation. Put more viscoelastic to deepen the AC and protect the corneal endothelium. We're going to put the phaco probe in. We're going to chop this nucleus in the bag. And again, it didn't spin with hydrodissection, so we're not going to rotate it. Buzzing with the phaco probe here, digging with the chopper, bring the two instruments together and apart, and then we have two halves. Now that's a pretty good split. We'll try bring up each half, about the iris plane, and we can sub-chop it more. Now this is an unedited case. It's going to take a little bit more than 7 minutes here. And I know a lot of the young generation likes edited videos and very brief videos, but there's a lot of learning in watching an unedited case start to finish. And that's what I want to bring you with this. So on a regular basis, we're going to start having these unedited cases start to finish. So we got most of the first part of the nucleus out. The first heminucleus is mostly out. Just a little bit of a piece remaining here. Taking our time, maybe sub-chopping like that. It's a good amount of nuclear density here. This is not some soft lens. A lot of nuclear density here in this patient. So the chopper's holding that second piece out of the way until we're ready for it. Now that we're ready for it, aim the probe over there, buzz in, and bring it up out of the capsular bag. Chopper goes around the equator, and we chop it into smaller pieces. Notice in this case, we didn't have any rotation after hydrodissection, and we didn't rotate the nucleus at all during the chop maneuver. So we left the nucleus as is in the capsular bag, chopped it in half, took out the right half. Now this is the left half. And then we're just still operating here at the iris plane. There's the last piece of nucleus. And the chopper's in our safety position just to be on the safe side, making sure the capsular bag doesn't come up. A little bit of an epinuclear shell. Let's see if we can get that with just the phaco probe. A little bit of vacuum, only vacuum here, no energy. Bringing that up, trying to just get a hold on it. If you give energy, it'll break off a little piece. I want this whole epinuclear shell to be intact so that I can bring the whole thing up into the AC and then emulsify it at that point. So just being careful there. You know what? Let's not push our luck. So there's a little bit of epinuclear shell left, but we can do that with the irrigation aspiration probe. So you can see the patient has a little bit of eye movement. They're under topical anesthesia. This patient's got a little bit of intracameral lidocaine as well. That's preservative-free lidocaine. And the patient in this case is getting very little intravenous sedation, and that's due to a lot of concomitant medical problems preventing significant sedation. There we go. There's the rest of the cortex and epinuclear shell. We'll get that out quite nicely. Wow, what a difference in the visual axis for this patient. This patient really is going to have an incredible transformation in her vision. Cleaning up the capsular bag there, a little capsule polishing if we need to, making sure there are no fragments that are remaining, and we're ready to put the lens in. So what was different in this case? Well, you saw at the very beginning when we put viscoelastic in this eye, we saw that it was very shallow in the anterior chamber. So we couldn't come across the AC like we normally do. We just had to start from near the paresthesis and just deepen the AC. You have to be careful also making orexis in these smaller eyes. If you don't deepen the AC enough, there's less working room. You want a good solid orexis. Here in this case, with a dense posterior subcapsular plaque, we weren't really able to get a good hydro dissection. And I was afraid of putting too much force in there in order to separate across that posterior capsule. So we just went without it. We chopped the nucleus in half in the capsular bag without rotation, then brought up the right half of the nucleus, further sub-chopped and emulsified it, then we did the left half the same way. Cortex removal was relatively routine. And now we'll go here, IOLs in the capsular bag. That looks great. Going underneath it, removing all the viscoelastic. We're also going to help this patient return to a normal anatomy. We'll deepen up that anterior chamber, open up that angle of the eye, because we've replaced that 4+ millimeter thick crystalline lens, which was the cataract. We replaced it with this thin IOL that's probably a millimeter or thinner. And that's going to allow the iris to sit in a more normal position, open the angle, and deepen the AC. Time to hydrate the incision here, so a little balanced salt solution, just in that mid-stroma. Again, we don't want too excessive, just a little bit. That ought to do it. And then we'll go in through the side port as well. We'll do angle sweep here, make sure there's no viscoelastic stuck in the angle. That's just injecting right at the angle. And let's seal up this incision as well. And you can see there's a really nice lens position, good overlap of the optic by that rhexis. Here comes a Wexel sponge soaked in tetracaine. And that's going to, of course, make the patient comfortable, but also help seal the incision. And then we'll use a dry sponge to make sure it's completely watertight, and it is. And this patient is going to have a beautiful result. I can tell you on post-op day 1, she was blown away happy. She achieved what she said was the best vision of her entire life. Thanks for watching. I encourage you to check out our website, CataractCoach.com. I love YouTube, so do you, but there's a lot more than this YouTube channel. If you go to CataractCoach.com, we've got full articles and pictures, and it's organized in a lot easier way, and you can search for any topic you want, like this showing here, posterior polar cataract. You can look up and see 10 videos about that. Check it out and join our free email list. We'll send you a new video every morning right to your inbox. Thank you.